Okay, so I think we can go ahead and get started. I'm Marielle Cobo. I'm an internist here at the Schwarzman Animal Medical Center. I'm very excited to be here moderating tonight. I know we have a great lecture in store for us. The title of tonight's lecture is Cognitive Impairment Across Aging Human and Veterinary Patients, presented by Dr. Vanessa Spano and Dr. Eileen Callahan. Dr. Spano is New York City's only board-certified veterinary behaviorist and the Schwarzman Animal Medical Center's first ever veterinary behaviorist. She currently serves as the service head of the behavior department at AMC. Dr. Spano received her board certification in 2023 after completing her veterinary residency with the American College of Veterinary Behaviorists, a college which includes less than 100 specialists in all of North America. Prior to her appointment as a senior veterinary behaviorist at the AMC, she served as medical director at the ASPCA's Adoption Center in New York City and as a veterinarian with the ASPCA's Animal Recovery Center, serving patients part of the humane law enforcement cases. Her professional interests include the implications of psychological trauma for patients part of cruelty cases, shelter medicine, and companion and farm animal welfare. Dr. Spano has authored multiple scientific publications and textbook chapters and is a recurrent lecturer for various veterinary schools, hospitals, and conferences. She and her family share their home with their one rescue puppy, Papilla, and five rescue cats, Little Prince, Dancer, Princess, Sunny D, and Brody. Dr. Eileen Callahan is a board-certified internist and geriatrician who has dedicated more than 30 years to advancing the care of older adults within the Mount Sinai health system. She earned her medical degree from the University of Medicine and Dentistry of New Jersey Medical School, and completed her internal medicine residency at St. Vincent's Medical Center in New York City, where she served as chief resident. She then completed a fellowship in geriatric medicine at Mount Sinai, where she was chief geriatric fellow. As professor of medicine and geriatrics at the Icahn School of Medicine at Mount Sinai, Dr. Callahan provides comprehensive primary care to a large panel of community-dwelling older adults. Her clinical expertise spans the full spectrum of geriatric care, with a particular focus on cognitive health. She recently joined the Dean Center for Cognitive Health, where she collaborates with neurologists, psychiatrists to evaluate and manage patients with memory concerns and other cognitive disorders. In addition to her clinical work, Dr. Callahan is a passionate educator, training medical students, residents, and fellows in the principles of geriatric medicine. She has received numerous awards recognizing her excellence in patient care and teaching. Dr. Callahan's career reflects her commitment to improving the health and quality of life of older adults through compassionate care, interdisciplinary collaboration, and education of the next generation of physicians. So with that, we're going to be getting started. Just as a reminder, the chat will be closed for the majority of the presentation, and then once we're about 30-40 minutes through, we will open it up, and you can type in questions towards the end, and we'll have some time for questions. And then we are also going to post a link in the chat that you'll need to fill out a form to get your CE credits. So with that, I will hand it over to Drs. Callahan and Dr. Spano, and they'll get started.
That's correct now,
That's
right?
perfect.
Okay.
Yes.
All right.
Thank you for sharing that, Dr. Callahan. And thank you for the introduction, Dr. Kovo. Welcome to another series of the Schwarzman Animal Medical Center's annual One Health Conference, bringing together One Health approaches to aging patients. So today, Dr. Callahan and I are going to be discussing cognitive impairment across aging. And you'll see some slides from myself, and then you'll also see some slides from Dr. Callahan going back and forth. There will also be objectives throughout the presentation to outline what we'll be talking about today. And just to disclose, Dr. Callahan has nothing to disclose, and I myself do not have anything to disclose either. So the first objective that we're going to be talking about today is comparing the changes that occur in the brains of aging humans, dogs, and cats. Next slide, please. So, cognitive dysfunction in cats and dogs is considered a neurodegenerative, often age-related disease. The prevalence has been increasing in recent years, likely as pets live longer as a function of better veterinary care, advanced nutrition, and protection from accidental death. As a result, the assessment of behavioral signs in aging pets should be included at veterinary visits for proactive treatment and monitoring in order to educate owners on quality of life and the consequences to welfare of this potentially progressive disease. Just to talk about some prevalence in our cats and dogs, a cohort study was done in 2001, and 180 dogs were looked at between ages 11-year-olds and up, and they were screened for four signs of cognitive impairment, which I'll go in a bit more detail later. But for conversation's sake, it was disorientation at home, alterations in social interactions, house soiling, and then alterations in the sleep-wake cycle. And in that study, 28% of dogs between 11 to 12 years of age had impairment in at least one of those categories. And that number increased to 68% when the dogs' ages were increased to 15 years of age and older. And similarly, another study was done in 1998 for cats, and it revealed that 36% of cats in those studies between the ages of just 7 to 10 years had some age-related behavior problems, including house soiling and changes to activity, and that increased all the way up to 88% to cats between ages 16 and 19 years of age. Next slide.
Oops.
So as I mentioned, we're going to be going over some of the changes that we see with this neurodegenerative disease. So I first want to go into the macroscopic changes that you might see anatomically, and then the microanatomic changes as well, perhaps to explain why we see some of these clinical signs. The changes to the brain that have been identified in both cats and dogs suspicious of cognitive dysfunction are actually a little bit different, even though there's some similarities. So in dogs, you'll see decreased frontal lobe volume, enlarged ventricles, and thickening of the meninges. And then in cats, we also see enlarged ventricles, but we also see cerebral atrophy, widening of sulci, and an overall decreased thickness of the cerebellar cortex. And so I just want to highlight that it's tough to truly attribute some of these findings to cognitive dysfunction versus actually just normal age-related changes in the brain. And so I wanted to highlight that using imaging as an example. I generally don't at this point recommend imaging to work up cognitive dysfunction. We consider it pretty low yield. So just to talk about one study, there was a study that was done by Arajo et al. In 2023 using CT scans, and they performed linear analysis of the cerebral ventricular system in poodles who were suspected to be senile, age 7 years and up. And they took measurements of the heights and widths of each of the left and right ventricles, the height of the third ventricle, and heights of the right and left cerebral hemisphere, as you'll see in the images on the right. And this study did find that the average ventricular measurements were significantly larger in senile poodles that were over 11 years of age relative to poodles that were younger, between 7 to 11 years of age, that were also considered senile. But the study contained no control groups, including similarly aged dogs that were designated non-senile to account for age. So that is all written out in the first chart at the top. The second chart at the top is another study that also investigated similar ventricular measurements for a different breed, though similar skull shape, which is Yorkshire Terriers. In this study, the dogs were not considered senile, so this was just as a function of normal aging of the brain. And you'll see that the measurements were lower relative to the senile poodles, but what can we conclude from this? It's tough. There's no singular reference range. Are there differences between normal age-related changes to the brain versus cognitive dysfunction, but also relative to that of different breeds or even different species? So in the next slide, I'd like to go over some of the molecular or microanatomic changes that we see. And so how did we identify that these changes were a manifestation of cognitive dysfunction versus just normal aging? There are studies which are referenced at the end that used validated scales, which I'll talk about a little bit later, to screen for cognitive dysfunction in the patients used in these studies pre-mortem. And then once they passed away, they looked at their brain tissue and they compared those that were suspected to have cognitive impairment based on those validated scales pre-mortem. And so, similar to what Dr. Callahan might present in humans, dogs and cats who scored higher on these cognitive dysfunction scales did have an abundance of diffuse and dense beta amyloid peptides, which you'll see at the right-hand corner, both as extracellular plaques and as perivascular infiltrates. And this has been identified in cats and dogs as early as 8 years of age, actually. The amyloid beta peptides aggregate into fibrils, which then causes microglia, the central nervous system's resident macrophages, to activate, to become dysfunctional. And they try to clear amyloid beta plaques, but again, they become dysfunctional, and this leads to an overall state, unfortunately, of neuroinflammation. And because of this neuroinflammation, you then get some neuroaxonal damage and death. And so we will also see microscopically a buildup of what we call NfLs, or neurofilament light chains, as those are the proteins found in the cytoskeleton of neuronal axons. And then you may also see diminished cholinergic function in the form of decreased brain muscarinic receptor density, compromising the neurotransmitter acetylcholine's effects on memory and synaptic plasticity. Interestingly, neurofibrillary tangles, which you'll see on the left-hand side, those form when tau proteins become abnormally phosphorylated and clumped together. But you may also see an increase in those neurofibrillary tangles with a neurodegenerative state that actually has not been identified to date post-mortem in dogs with cognitive dysfunction, even though it has been in both human and cats. So just in talking about the molecular changes that we see on the next slide, I relate those to how that might lead to a pathophysiologic state. And so on the left-hand side of this slide is the NMDA neuronal connection, which is very much involved in long-term potentiation. Long-term potentiation is a fancy word for the strengthening of synaptic connections, which is really important in learning. And the neurotransmitter that's involved in that is glutamate, and glutamate binds to the NMDA receptor. As you'll see, it's released from the presynaptic neuron, goes through the synapse cleft, and then goes into the postsynaptic neuron. In the disease neural connection on the right-hand side, the picture that's next to it, you see that there's actually an influx of calcium into the postsynaptic neuron. And the reason why that's happening is because the blue squiggly is actually an amyloid beta plaque that's binding to the NMDA receptor and activating it. And that ultimately leads to a state of excitotoxicity because of the influx of calcium into that postsynaptic neuron. And that influx of calcium impairs cellular mitochondria and induces oxidative stress, ultimately leading potentially to neuronal death. And as I mentioned earlier, just a chronic state of neuroinflammation.
Okay, I'm trying to get this, sorry, I'm trying to get this off. I don't know if you can see that.
Yeah.
Okay, sorry, I have it back on track now. So I'm going to give a few slides and a little discussion about the prevalence of cognitive impairment in humans. And as Dr. Spano said, this is really a disease of later life. We see it more after one hits 65. Most of the prevalence data that I will share and that has been found is really based in Alzheimer's disease, not all of cognitive impairment. But at about 65 years old, the prevalence data is about 10%. So 10% of people at the age of 65 will have Alzheimer's disease. the prevalence doubles every 5 years after the age of 60, whereas up to 45% of adults over the age of 85 will have some evidence of clinical Alzheimer's disease. And I preface this by saying I am not a neurologist. I'm going to give a very simple schematic of the function of the brain and the brain anatomy. What we do know is the three areas that I have circled here in red are really the focal points of where the neurodegenerative disease occurs. The parietal lobe is on the top part of the brain, the frontal lobe is the front, the temporal lobe is over to the side. And as you can see, these are specific features of these areas of the brain. And then there's the occipital lobe, cerebellum, and the brainstem. But these are the three areas for the most part that are affected by dementia. And again, a very simple diagram of what happens in the brain as one ages. It's very similar to what Dr. Spano was saying that you see in cats and dogs. In general, the overall volume and the weight do decline with age at a rate of about 5% per year after the age of 40. And that does increase that rate of volume loss after the age of 79. One of the things that we do see, these are the classic findings that, again, she pointed out are seen in cats and dogs. The ventricles enlarge, there's cortical thinning, there's overall volume loss, and then the sulci widen. So this is what we see in older brain MRIs. There is some variation in the volume, diminishing volume in the different areas of the brain, different depending on the disease state, and also according to whether you're a male or a female. In men, they find that there's more shrinkage in the prefrontal cortex and the temporal lobes, and in the women, they have more hippocampal volume loss and parietal lobe volume loss. But how does that translate clinically? It really is hard to say because there's other factors such as lifestyle changes, genetic factors, hormonal changes. So it's really hard to translate that into clinical significance. The second objective that I'm going to be starting off with is recognizing how these changes present clinically. And this is what I do. The spectrum of cognitive changes with aging is really very variable. It's not just a black or a white. You don't just develop dementia overnight. There's changes that occur as one ages. And what does this normal? It usually starts with normal aging. This is what a lot of people get really afraid of when they start having a little bit of slowing of their memory. So we usually say there's a little bit of mild slowing of one's memory. A little processing takes a little slower, a little pulling, the retrieval of some of the memory changes also. We usually think of memory, and again, this is a very simplistic approach. This is the geriatric approach, not necessarily the neurology approach, but there's semantic memory and episodic memory. Semantic memory is that factual knowledge that everybody has, right? The sky is blue, the grass is green. That may slow down a little bit as one ages, but it's usually there. You don't really have much problem with that. Episodic memory can change in terms of the episodic memory is things that are personal to you, remembering, an event, remembering a vacation. You may have a normal older person may have a little trouble free recall. They may need a little clues or cueing, but that is usually preserved. The other features of normal aging are occasionally misplacing items, right? Misplacing your phone, your keys, not necessarily putting your phone in the freezer, but just where did I put my stuff? Another feature of normal aging is struggling to find a word, but then remembering it later, that tip of the tongue phenomena. Forgetting the name of an acquaintance, somebody you really don't see on a regular basis, but eventually the name comes to you. And then challenges with new technology. As we all know, technology can be challenging for our older adults. The key features of normal aging are as the person is still independent in their daily life. There's no changes, there's no there's no problems in their living their regular life. And when they do get an evaluation in the office, their memory testing is normal. And I'm going to go into that later on. So the memory testing in the office is normal. I love this cartoon because it really says it all, right? Technology is challenging for our older adults. So as some patients move along on this spectrum, and again, not everybody will move along on this, there's this term called mild cognitive impairment, MCI. It's kind of this intermediate stage of living. It's a cognitive decline beyond normal aging. But there's still no functional decline. They're still independent. And when I say that, we talk about the IADLs, the independent activities of daily living. The common ones that we see faltering first are paying the bills and managing medications, the things that take a little bit higher cognitive functioning. The patient will complain of memory problems, and the office testing that we do may be a little abnormal. So, but they're still functionally independent. Some patients may progress to a dementia, and there's a lot of different categories of mild cognitive impairment. And some are more predisposed to developing dementia, but not everybody will. And dementia is not part of normal aging. So, what is this dementia? Another term that is being used in the psychiatric world is major neurocognitive disorder. It really is a large group of disorders that can cause significant decline in one or more cognitive domains, and it results in a functional decline. And I'm going to go over into these more details. The common ones that we see are Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and then which I'm going to talk about those. There's also normal pressure hydrocephalus, NPH, and Parkinson's disease that can develop dementia. And I will not talk about those. Sorry. Sorry, I'm in my office. So what is dementia? It's really a memory problem and cognitive deficits that interfere with the independence in everyday activities. The symptoms can vary from day to day. They can vary from person to person, but in general, they're all unfortunately progressive and usually incurable. So what does this mean? I usually try to break it down into what the domains of impairment are, and then what actually a caregiver, family member, friend, patient sees. So first, learning and memory, right? You have trouble learning new events or remembering new events. You forget the names of close contacts or even common items. You forget the names of some of these things. Executive functioning is a broad category. These are the things that we all do every day, managing our finances, managing the medication. A person may have trouble with those problems or those tasks. They may have trouble following complex recipes. I hear this a lot. Mom can't do Thanksgiving dinner anymore where, she's kind of heating up things now. Attention is also a domain, so the person may have trouble paying attention in a conversation. Aphasia, people develop problems with language. They have aphasia, they have trouble finding some common words. And visual spatial impairment is also a common problem. The patient may fall more, and it's not necessarily a leg weakness. They just have trouble with their surroundings. A common problem we see is getting lost in familiar environments if they get put in a place where they just get disoriented and they can't figure out how to get to a place. One of the things that we do also see in somebody with a dementia are these changes. And a lot of families don't realize this can happen. So their personality can change. They develop more impulsive behavior, OCD kind of behavior. Mood disorders are very common in older adults. And recently, we found that late life depression can actually be a precursor for developing dementia, but also people with dementia do develop anxiety and depression. Those are common. Sleep patterns can be changed a lot. The neurodegenerative pathology can actually affect the area of your brain that manages sleep-wake cycles. So the triggers that will trigger the influx of that cues that will help somebody maintain the appropriate sleep-wake cycle, they can be affected by this disease. And lastly, a huge problem that we see is lack of motivation. And there is a term called dementia with apathy. It doesn't bother the patient. It's exactly what it says. They just don't want to, they're not motivated. They just want to stay home. They may want to lay in bed. They don't want to do anything. The patient's not bothered by it. It's the caregiver that's really bothered by it. And then moving along as the dementia progresses, which inevitably it does, but at often different rates, the person may develop difficulty doing the simple tasks. They may have trouble just even brushing their teeth, choosing the appropriate clothing for the event, the weather. Hygiene becomes a problem too. That's something that we see. They just don't shower and bathe appropriately. They can forget details about current events. So that's that repeated question of when's the doctor's appointment? What are we doing today? What are we doing today? Forgetting events in one's life, forgetting the daughter just visited yesterday. Eventually, people do develop problems with walking, even problems with swallowing. We see this more end stage dementia, having some dysphagia. There's another huge problem that patients suffer from is BPSD, is behavioral and psychiatric symptoms associated with dementia. Those are the hallucinations and delusions that are very common, usually later stage. When I diagnose this and I counsel patients on this, I usually say dementia is the umbrella term. It's the type of dementia that we, have to do some investigation on, and that's these types, which I'm going to go over. Alzheimer's disease is the most common type of dementia. It usually occurs after the age of 65. That's what we see more, and the incidence will double every 5 years. Memory complaints are early. That is an important feature because when I talk about the other types of cognitive impairment, they differ a little bit. The memory complaints are seen early. And just as in Dr. Spano spoke about the amyloid deposits, that is a key feature that we do see in the brains of Alzheimer's disease patients and even other patients with other dementias. There is this syndrome called asymptomatic Alzheimer's disease because what they're finding is they're finding these amyloid deposits maybe 15 years in one's brain, even before clinical signs are being seen. So what is this pathophysiology of Alzheimer's disease? Again, it's very similar to what Dr. Spano was talking about in the brains of cats and dogs. They're amyloid plaques. These are these clusters of these abnormal proteins that form in the spaces between the nerve cells. And then there's these neurofibrillary tangles, similar again to what Dr. Spano's talking about, these twisted up damaged nerve cells, these abnormal tau proteins. These are the neurons that are damaged. It really is unclear if these are truly the only cause of the Alzheimer's disease, or could it be a byproduct of the disease? Because there are other risk factors associated that we see with Alzheimer's disease, and hence, that's how we try to treat some of these patients to help prevent further cognitive loss, treating the risk factors, which I'll go over later on: blood pressure control, lipid control, and then, of course, there's genetics. But the genetics really are a small percentage of patients that have Alzheimer's disease. And even if you have this ApoE 4 allele genetic problem, it doesn't necessarily mean you are going to develop Alzheimer's disease. And then the second type of dementia, and I say second/third, it depends on the studies in the population, usually in regular primary care clinics. Vascular dementia accounts for the second most common type of dementia. And what do we see? It's these white matter changes you see on the MRI. And it could be large vessel disease, it could be small vessel disease, it could be a hemorrhagic problem, it could be a poor blood flow problem. We often see mixed dementia. All right, we do see a lot of patients with vascular dementia signs, clinical signs of vascular dementia, and imaging signs of vascular problems and Alzheimer's disease. We see that a lot. We usually think of it having a stepwise decline in cognition, but that's not always the case, right? We could see it can present in two different ways, where you make the diagnosis in two different ways. If somebody presents with an actual clinical stroke, what we all know of as a clinical stroke, the focal weakness, the facial droop, and then they develop cognitive impairment after that. That's the first way. The second way is somebody has dementia. They have those risk factors, and then you do this imaging and you see all this white matter changes. So those are the risk factors that we all know we should be treating as high blood pressure, diabetes, cholesterol, and smoking. Lewy body dementia is second, maybe third most common type of dementia. This is what Robin Williams was diagnosed with. And they do have these clinical criteria, which they do update regularly to improve sensitivity and specificity. And the last time these criteria were updated was back in 2017. The three key features you really need for this are a Parkinsonism type of tremor, that resting tremor, Fluctuating alertness or attention. This is where there's more of an acute problem. They may act out, they may zone out, they may just act bizarre. There's something different about their attention and alertness. They develop visual hallucinations. And again, this is a really key feature that we see and helps make the diagnosis. The classic visual hallucinations are seeing small children or animals, but it could be any visual hallucination. These patients also commonly develop REM sleep disorder, the rapid eye movement sleep disorder. And one of the things that the partner usually will say is they're acting out their dreams. They're having wild, wicked dreams. They're thrashing in the middle of the night. They wind up on the floor, wrapped up in their sheets. So that's a REM sleep disorder. The other features that we see are dysautonomia. So they may develop like a neurologic problem like orthostatic hypotension, constipation, urine problems, hypersomnia, where they have excessive daytime sleeping, or hyposmia, where they have difficulty smelling. It is diagnosed with certain dopamine SPECT imaging studies or a special PET scan that just looks at glucose metabolism in different parts of the brain. These patients usually present younger. Again, Robin Williams in his 60s. Men are higher risk, and they also progress more rapidly than Alzheimer's disease does. The third type of dementia, or the fourth type of dementia that I think warrants presenting, is one that Bruce Willis has. The frontotemporal dementias are really a bunch of different types of dementias. It's a heterogeneous syndrome. It could either be an aphasic variant or a behavioral variant, right? Your frontal lobe is affected. So they have personality changes. They have different difficulties with language. And that's what he had presented first with. That's what they had mentioned. They have aphasia. These also have a executive functioning problem early on. So they have problems with planning early in the disease. They may be at work and their coworkers notice that something's off. The memory may be preserved till later. And again, this usually starts prior to the age of 65. These are the patients my neurology colleagues see more often. Again, a much more rapid progression than Alzheimer's disease. And Dr. Spano.
Thank you. So, how do the pathophysiological or molecular changes that I had discussed really manifest clinically? For example, the cholinergic hypofunction, the amyloid beta plaques, the compromise to long-term potentiation, and just this overall state of neuroinflammation. Clinically, that's where in veterinary medicine we use the acronym DISHA. So that is DISHAA. And I'll go into some of these specifics in another validated scale in a later slide. But just to say what they stand for, D stands for disorientation. I stands for alterations in social interactions with other pets and people in the home and others outside. S is a change in the sleep-wake cycle, similar to what Dr. Callahan had mentioned for her patients. H stands for house soiling, but it's really highlighting memory impairment, losses in potty training, or previously known cues like sit, stay, down, etc. The first A is for changes in activity. And then the second A, anecdotally, is what I feel like I see more often. And that is also similar to what Dr. Callahan had mentioned, a later onset of a change in behavior, or more often than not for me, it's a worsening of pre-existing anxiety disorders like worsening of noise phobia, separation anxiety, aggression. Next slide. So the next and the third objective is to understand how a comprehensive evaluation in each species is done, and to compare the different diagnostic modalities that are available in human versus in veterinary medicine. So, as I alluded to earlier, diagnosing cognitive dysfunction in cats and dogs at this point is really mostly presumptive. It's a great highlight that a lot of behavioral disorders are really diagnoses of exclusion. It's based upon patient observation and history taking, subjective scales. Yes, they're subjective because they're based upon the bias of the person filling them out, though many of them have been validated, and I'll talk about one next, but also ruling out other potential concurrent medical conditions that could be causing the clinical signs. I mentioned earlier on in the lecture that unfortunately imaging doesn't really yield a definitive diagnosis. There's no formalized reference scale which could discern suspect neurodegenerative changes from those that are age-related. And there's, like I mentioned, multiple confounding factors in terms of reference ranges, in terms of species and breed. Also, to take into consideration from a veterinary aspect, imaging like that, such as an MRI or CT scan, would require general anesthesia to minimize movement, which could be cost prohibitive, especially if it's not covered by insurance for our patients, and it may come with additional risks dependent on the patient's other medical comorbidities. And finally, in veterinary medicine, we do have a focus on quality versus quantity of life. And outside of a structural lesion, but even if you do see a structural lesion like a brain neoplasia, if you were to identify that, is it going to change the treatment plan that much, depending on how far you want to go, outweighing the potential emotional stress to an already compromised pet that is involved with this invasive medical handling and continuing care? Um, there is some recent research beyond imaging on biomarkers, which yields conflicting, but also maybe some promising results. The area of promise based on the research that I could find is specifically serum levels of those NfLs, the neurofilament light chains, which build up when there's neuroinflammation and neuroaxonal damage. Dogs who were deemed senile based on validated scales showed threefold increases in neurofilament light chain serum levels when compared with normal aging controls. But that is right now in the research. It's not, as far as I'm aware, commercially available yet. Um, Measurement of tau proteins in dogs is just not reliable via plasma, maybe in cats, but more research needs to be done with it. And then, I did talk a lot about postmortem, the buildup of amyloid beta plaques. Multiple studies in dogs similar to humans have identified postmortem, the specifically of amyloid beta 42 peptide in the brain, particularly in the prefrontal cortex, the temporal cortex, and the hippocampus. And it was found in another study that those dogs post-mortem that were tested and suspected to have a cognitive dysfunction pre-mortem had a positive correlation with higher scores of the amyloid beta 42 peptide, but these were not supported when we used mediums like cerebrospinal fluid or serum pre-mortem, even though you might expect that you should see declining levels in the serum because of the buildup in the central nervous system, but that actually wasn't identified in the study, so it's just not consistent. So in the next slide, I'm going to go over one of those many validated scales that I do keep talking about. And this is with the acronym CADES, C-A-D-E-S. It stands for Canine Dementia Scale Worksheet. And in this one, the owner or the caretaker of the dog will go through different potential clinical signs of cognitive dysfunction and rate each of those signs based on their observations on a 5-point Likert scale, with 0 points meaning that the individual never really observed that abnormal behavior in the dog, all the way up to 5 points where that abnormal behavior was observed several times a week. The scores are then added up at the end, and then the overall score might tell you the clinical stage, so to speak, of cognitive dysfunction if there is. If the score is between 0 to 7, that's actually correlated with normal brain aging. But scores between 8 to 23 indicate mild cognitive impairment. Between 24 to 44 indicate moderate cognitive impairment, and scores between 45 all the way up to the highest score, 95, unfortunately, indicate severe cognitive impairment. And so this utilizes that DISHA acronym that I had previously mentioned. But in terms of D for disorientation in this scale, they use spatial orientation. So for example, is the pet seem to not recognize that they're in a familiar environment or recognize familiar people? Are they not purposely walking into a wall, but they walk towards a wall or a corner and you have to snap them out of it in order to get them out of it? Then there's social interaction, changes in social interaction. So are we seeing now fear and anxiety in social interactions, whereas the dog used to be pretty docile, or even aggression, or vice versa? There's also changes in the sleep-wake cycle. Do we see that they're excessively sleepy, hypersomniac during the day, but then we also see restlessness on the other hand at night? And then house soiling, but like I said, that's a loss of memory and cues. Are they losing their potty training? Are they not recognizing different commands or cues that they used to know, like sit or stay? Are they staying in different locations or unusual locations where they normally wouldn't stay or sleep? So you would just with the owner score that and come up with an ultimate score at the end. Um, so in the next slide, like I said, one of the um, highlights of cognitive dysfunction in cats and dogs is memory impairment. And certainly with history taking and video recordings, it could be relatively easy to identify house soiling issues, disorientation in the environment, and sleep-wake disturbances. But it's hard to identify memory impairment specifically in a cat or a dog beyond loss of training cues if they know them. And again, sensory impairment could impair that. Is the dog not able to see your hand's cues very well or hear your cues very well? Of course, which signs of cognitive impairment related to memory may manifest depends on which region of the brain is affected, as Dr. Callahan had alluded to with her own patients. And we could see deficits depending on the area in the brain on learning, recall, psychomotor ability, attention, or even spatial abilities. So one way in the next slide to test for memory impairment is by using neurocognitive assessments. It can be hard sometimes for owners to carry this out, and a lot of this has been done in the research, but it doesn't hurt to try, including in the clinic, although that is certainly a novel environment, which can affect the results. But one example of a neurocognitive assessment, as you'll see in this simple diagram, is something called the treat, hide, and seek activity. And it involves a delay. So initially, the dog is in the center of the room, someone's holding the dog on leash, and someone places a reward into only one of two containers that the dog can visually see. In this diagram, the food is placed in the container on the left, and the one on the right is kept empty. Then both containers are covered. The dog is held on the leash for a delay of up to 40 seconds and is then released to observe if the dog goes to the first container, in this case, which the reward was placed. I personally feel that there could be some confounding factors because scent is so strong in dogs. Are they just going after where they smell versus what they remember? But it certainly is a neurocognitive assessment to consider. And one study found that dogs exhibiting impairments during such a neurocognitive assessment actually also demonstrated other signs of cognitive impairment like sleep-wake cycles, increased stereotypy, which is just repetitive motions, and decreased social contact with humans, unfortunately. Um, and then finally, I want to go into rule outs to consider to make sure we're not missing anything underlying medical. So one of the first things the veterinarian should ask is, what are the current medications, or are there any new medications that the patient is taking that could potentially be impacting their memory and their behavior, such as steroids or medications with anticholinergic effects. For example, antihistamines like diphenhydramine, Benadryl, or even some antidepressants like the tricyclic antidepressants like clomipramine, which is in dogs is branded Clomicom. Of course, the veterinarian should conduct a thorough history taking with the owner, maybe observe some videos if there are, perform a thorough physical exam and any indicated diagnostics, and other medical rule outs to consider as you're going through your diagnostics is sensory impairment, decreased vision, decreased hearing, which can be really tough to discern in a cat or a dog because the vision testing is not as extensive as it usually is when we go to an ophthalmologist or an optometrist. Of course, neurologic lesions, intracranial versus extracranial, endocrine and metabolic diseases, hypothyroidism in dogs, hyperthyroidism in cats, hypertension, hepatic disease, renal disease, Cushing's, Addison's, functional gonadal tumors. Believe it or not, I suspected in one of my cases uh, a um, a Sertoli cell tumor potentially in a poor kitty, among others. And then what I really want to highlight, which I feel like is unfortunately underdiagnosed by the time the patients come to see me, is any disease that can cause discomfort or pain, whether that's gastrointestinal, dermatologic, and especially musculoskeletal orthopedic. I have definitely seen dogs as they age and they are more painful, get more restless at night. Perhaps the arthritis and the movement is building up during the day and they get really restless at night. There's a lot of studies into the comorbidities between noise sensitivity and pain in dogs, and that dogs with pain are less tolerant to noises. Let's just say that the dog is uncomfortable on the surface that they want to lay on, and but they have osteoarthritis, and so they seem restless at night. Or now all of a sudden they're resistant to going out on walks, but it's because they're painful. They have hip dysplasia. Maybe the poor kitty is house soiling, urinating, or defecating outside the litter box because of discomfort when posturing to eliminate and getting into a very tall-sided litter box. And of course, the pet may become aggressive because when they are touched in the place that hurts, it's painful. And so then they start to develop anticipatory pain. And then when you have chronic untreated pain, you also get wind up pain where your pain receptors become hypersensitive. I just wanted to highlight this quickly. In a retrospective study of 100 cats, 82% of those cats aged 14 years and older had radiographic signs of osteoarthritis. Of cats that were just 6 years of age and older, 61% had radiographic evidence of osteoarthritis in one joint, and 48% had it in multiple joints. And unfortunately, only 13% of cat owners out of that 61% reported noting any of those clinical signs. So relying on history taking just might miss this. And then in terms of ruling out other diagnoses, we also want to consider behavioral. For example, sundowners, which is a change in the sleep-wake cycle due to a circadian rhythm disturbance, but also, as I mentioned, pain-related and irritable or pathophysiological anxiety or aggression. I do want to highlight here that unless there's been a clear environmental stressor contributing to an uptick in anxiety, fear, aggression, or unless there's truly a neurodegenerative disease, it's really unlikely to see a primary behavioral disorder like anxiety or aggression develop all of a sudden later in life. We see these develop during social maturity in adolescence, which is between 6 months to 3 years of age in dogs and 6 months to 18 months of age in cats. And the reason why we see the onset of a lot of behavioral disorders during that time and not after is because of the degree of neuroplasticity that's going on in the brain that de-escalates past social maturity. So if you have a patient come to you that all of a sudden has a brand new behavior later on in life and it doesn't seem to be cognitive dysfunction, I would be making sure that we're not missing anything medical, especially pain.
Okay, I'll take it from there. So what do we do in our humans for our evaluation? Very similar to what Dr. Spano said. We take a really extensive history. These visits can take about 90 minutes at a minimum sometimes. We want to hear the patient stories. We want to hear the family stories. Give us some examples of what you're noticing. We do cognitive testing. We can do it in the office, or some patients get referred to a neuropsychologist, which does about 3 hours of testing. We evaluate their mood with the PHQ-9. We do a functional assessment, and there's a difference of an ADLs and IADLs. It's ADLs are what the basic activities of daily living. I usually say it's what kids have to do to get into kindergarten. IADLs are what young adults have to do to get into college, and you can look those up. Medication review, exactly the same thing. We always look at prescriptions and over the counters. Of course, as you get older, you get more and more medications thrown on you. The diphenhydramine is a big no-no. Any of these anticholinergics, you want to eliminate. Really good thorough physical exam, some of the blood works and brain imaging. The blood work is very similar to what Dr. Spano was talking about. We look at thyroid function tests, we look at B12 levels, but most of the time those are not really going to be a problem. Some of the things that we look at are the blood or CSF biomarkers, which I will go over later. That is not necessarily standard of care. The brain imaging, the American Neurologic Association does recommend some initial brain imaging. Either a CAT scan or a more sensitive test would be a brain MRI if they can undergo that test. The other testing are those PET scans that can look at glucose uptake. There are the amyloid PET scans that are available now, and Medicare does cover these. But again, that's not necessarily a standard of care. This is an example, if anybody's ever seen this, this is the MOCA. This is a 30-item test that we do in the office. It takes 10 or 15 minutes. And if you look, it covers 7 different domains, right? Visual, spatial, executive functioning, naming of the animals, memory, attention, language, abstraction, delayed recall, and orientation. All right, takes about 10 to 15 minutes to do. Some of the blood or CSF biomarkers that are one of them is commercially available now. But what we do here at Mount Sinai is part of a research project. We can do p-tau 181 levels, p-tau 217 levels. They do the alpha amyloid beta 42 or 40 ratio blood tests and CSF markers. These are not recommended for routine screening, mass screening, or widespread use, but it is recommended in some instances as part of a full evaluation to support your clinical findings. That my neurologic colleagues do use these more commonly in those patients that they see under the age of 65 to evaluate for Alzheimer's disease. So that's the evaluation. How do we help these patients? I'm just trying to be cognizant of time. I tell every one of these patients, keep mentally, physically active. Don't try to multitask. You cannot multitask as you get older, even with normal aging. Organize your tasks into manageable parts. Keep a calendar, keep lists of things. Learn the local resources. In New York, we refer and work with Caring Kind NYC and als.org.
Similarly, in terms of an environmental management and behavior modification or training standpoint in cats and dogs, there's stuff that we can do outside of medication and supplements, which we'll talk about in a bit. From an environmental management standpoint, consistency and routine is key when it's possible. I've definitely seen patients with cognitive dysfunction where they seem to develop regressive behaviors when the owner is traveling, or there's just a major change in routine or environment. Um, Account for sensory decline, take into consideration new odor, tactile, and sound cues to counteract visual or auditory decline. Avoid startling a patient, for an example, that's losing their hearing or vision when they're asleep and then they startle awake. That's not very fun. Dogs with house soiling, if there's loss with those cues, may require more trips outside or to an indoor toilet area to prevent accidents. And for cats that are painful, litter boxes with lower sides and non-slip ramps. Consider mobility. So providing ramps, floors with good traction, and other physical support devices for mobility, as slipping and sliding can be scary for anyone. And implementing a maintenance of as much of a day-night cycle as you can, opening blinds during diurnal hours, providing outdoor activities during daylight, reducing exposure to artificial light at night, and also cats and dogs do tend to sleep after they play and after they eat. So for those with nocturnal activity, playing and providing a meal right before bedtime may help you and may help them. And in terms of enrichment, mental stimulation can help maintain cognitive function. For example, training at previously known cues, sit down, stay, relax, whatever it is, as long as it's not overwhelming the pet. Keeping toys novel by rotating with them and playing, not high energy play that's going to be painful. Be consistent with positive social interactions, reward for good behaviors, ignore for bad behaviors. It's not good to punish, especially if the patient is exhibiting a house soiling behavior out of cognitive dysfunction because of memory impairment, unfortunately. Allow for species-specific exploration, climbing, perching, hunt and chase games in cats, and nose work and scent work in dogs. And finally, we're going to talk about the different treatment options that are available. So I just wanted to highlight quickly the use of certain veterinary prescription diets. Let's go into nutrition. I did see a question about this actually. So fortified diets that are rich in omega-3 fatty acids have consistently been found not only to improve clinical signs of cognitive impairment, including in those neurocognitive assessments in the research as early as 2 to 8 weeks after initiating treatment, but also some of them, like Hill's Science Diet, Brain Care, and JD, also contains byproducts to improve the pain and mobility by reducing the expression and activity of cartilage proteoglycan degrading enzymes. These diets will contain things like antioxidants, omega-3 fatty acids, including phospholipids, and mitochondrial cofactors to reduce the negative effects from free radicals. And aside from diets, in the next slide, I do go over some supplements. The dosing is there for you in that chart, but just to highlight a few, Senalife has been used for a long time. Even though there's not really any efficacy studies in cats, it is labeled for both dogs and cats. And it contains antioxidants, phosphatidylserine, if I'm pronouncing that right, which is a membrane phospholipid similar to the omega-3s. It contains vitamin B6 and vitamin E, which help with the availability of certain important neurochemicals like serotonin, dopamine, and adrenaline. Then there's NovaFit, which actually contains SAMe. That also improves the turnover of some of those neurochemicals considered monoamine transmitters, serotonin, norepinephrine, and dopamine. And then more recently, there's CogniCaps, which contain a lot of what I just mentioned, SAMe, phosphatidylserine, vitamin E, also coenzyme Q10, which is an antioxidant, and then a blend of Chinese herbs. It also contains curcumin, which is anti-amyloid, anti-inflammatory, and antioxidant. And then, of course, melatonin to help with sleep, 30 minutes ideally before bedtime. So next, I'm just going to quickly go over the medication options. I wanted to highlight the one medication that is branded for dogs with cognitive dysfunction, but it's not personally my favorite because there are some contraindications, some drug interactions, and if it doesn't work and we want to switch them to an antidepressant, it can take a long time to get them off until we get to a new antidepressant. It does contain three principal metabolites: L-amphetamine, L-methamphetamine, and N-desmethylselegiline. And the reason why I say that is that's equivalent to speed. And so you definitely would not want to give this at night, especially if there's sleep-wake disturbances. You may want to consider giving it in the morning if you do give it. There is reason as to how it could work. It's a selective and irreversible inhibitor of monoamine oxidase B, which ultimately means it prevents the breakdown of a variety of those biogenic neurotransmitters, so serotonin, dopamine, adrenaline. But because in cats and dogs it's selective and irreversible, if we want to get them off of it, it takes 5+ weeks, and then we can get them on a different antidepressant if we wanted to. It also can be neuroprotective with the activation of astrocytes, mobilization of humoral factors, and enhances antioxidant effects. It can take 2+ weeks to see improvement, but there certainly are efficacy studies. For example, in a study by Campbell et al. In 2001, they reported that 77.2% of dogs with clinical signs of cognitive dysfunction improved after treatment with selegiline for 60 days or 60 days later. It was discontinued in that study in 5% of dogs due to side effects like GI upset, lethargy, ataxia, or really, really rarely seizures, which I have never seen, but I guess is possible. So in the next slide, I'm going to conclude my portion with the medications that I do tend to reach for first. I really should highlight if it truly is cognitive dysfunction, it is a progressive disease. So unfortunately, it's important to highlight to owners that there is no cure. If anything, it's perhaps making the patient more comfortable, less anxious, and also slowing down the progression. So one medication that I really like to reach for is memantine, is the generic name. And how does that work? So if we go back to the pathophysiology of how long-term potentiation or learning is affected, it's because of excitotoxicity at NMDA neural connections due to the amyloid beta plaques. And so memantine is a low to moderate affinity, uncompetitive NMDA receptor antagonist, blocking those overactive NMDA receptors, which are dysregulated by the amyloid beta peptides. This ultimately reduces the excitotoxicity by reducing excessive calcium influx into those neural circuits and restoring hopefully healthier synaptic function. It has not been used in the research for dogs with cognitive dysfunction, but I have used it. I've seen pretty decent results, but again, it's a slowly progressive disease, so it's just about slowing that progression. But it is used in the research for compulsive disorder because glutamate, which binds the NMDA receptors, is also involved in OCD or compulsive behavior. And it's generally tolerated well, though, of course, we could see side effects like GI upset, lethargy, worsening of behavior, in which we just discontinue. And finally, the other medication that I may reach for is Keppra. How does that work? It's neuroprotective, so it upregulates the expression of glial glutamate transporters, removing excess glutamate from those excitotoxic neural connections to prevent that excitotoxicity. This can lead to improvements in motor and memory performance. You could also consider more standard behavior medications to decrease anxiety and help with sleep. For example, trazodone, gabapentin, selective serotonin reuptake inhibitors. But again, there's a risk of serotonin toxicity with selegiline because of the irreversible monoamine oxidase B inhibitor. And so we definitely do not want to use something like an SSRI or trazodone with selegiline. You could also consider benzos if it helps the patient sleep at night, though just be caution. And I know in human medicine, it may be a little bit different because of the impairment and disorientation. We want to also make sure we're not missing any important analgesia. And then finally, I do want to highlight an area of potential research. I'm just not aware of it actually being used in veterinary medicine. Because of the cholinergic hypofunction, to improve memory, you would think, well, what about increasing acetylcholine? What about acetylcholinesterase inhibitors, like, for example, one that we use, pyridostigmine, in dogs with myasthenia gravis, or dogs and cats with both of that? Um, this has been done in studies in laboratory beagles that were not senile, but were aged with the medication donepezil. And when they were given donepezil, they did seem to show improvement of the performance of neurocognitive assessments. Um, this is because it's thought to block acetylcholinesterase, increasing or preventing the breakdown of acetylcholine, so increasing acetylcholine to improve memory, especially at the hippocampus. But more research needs to be done on the ability of these medications to cross into the central nervous system to have the desired cognitive effects, bioavailability, safety profile, and side effects. So we just don't have any practical research on that at the moment.
I'm gonna just check. We're past the hour. Should I keep going? I will. Okay.
Yes.
So what do we do? Similar things for humans with dementia. I'm gonna try to be fairly quick. This was a wonderful picture that I love using. It's from the Lancet Commission on Dementia Prevention and Intervention. It was updated in 2024, and this just a nice diagram that highlights all the different things that a person can do to help preserve their brain function. And this is really starting in early life through midlife and late life. All right, I'm gonna try to go a little quick to get to the end. Lifestyle, we always recommend aggressive lifestyle changes, physical activity of any form, high intensity, low intensity, aerobic, resistance training, concurrent training, meaning, the weights and resistance training and aerobic activity, dancing at the same time. Those are all really important to help with brain function. The MIND diet is a combination of the Mediterranean diet and the DASH diet, which really is what the healthiest diet. And the MIND diet will focus more on berries and green leafy vegetables. Again, exercise. I tell my patients now is not the time to become a couch potato, because there's clinical changes and physiologic changes that they show can be improved with physical activity. The medications. Very similar to what Dr. Spano was mentioning. We use cholinesterase inhibitors a lot. They are FDA approved for any stage of dementia, but there are some key usages for cholinesterase inhibitors. In Lewy body dementia can actually help prevent and lessen these hallucinations. They have been shown to help patients with behavioral problems decrease the use of antipsychotics. And rivastigmine, one of the medications, is approved for FDA and is approved by the FDA for Parkinson's dementia. These are the three cholinesterase inhibitors that have been out there: donepezil, galantamine, and rivastigmine. There's really no data to support one being better than another. They've been around since 1997. And again, as Dr. Spano said, we use them a lot. They're not a cure. In a small percentage of patients, they may help slow the progression. More recently, there were studies out of Sweden that show some benefits long-term over 5 years of usage. Again, lower risk of antipsychotic use for behavioral problems, slower decline in their cognition, lower risk of death, and really importantly, lower risk of progression to severe dementia. They're really well tolerated. Some of the side effects are nausea, vomiting, diarrhea, anorexia, but that's in a really small percentage of patients. Some patients do report vivid dreams that they have to stop these medications because they're not getting a good night's sleep. There are some reports of increase in cardiac basal tone that may cause bradycardia. Again, these are very well tolerated medications. I'm not going to mention the memantine. Dr. Spano went into a great discussion of that, but that has been around for many years too, and it is FDA approved for patients with moderate to severe Alzheimer's disease, with small benefits seen in cognition, function, and neuropsychiatric symptoms. We do use that in combination with the cholinesterase inhibitors, or in those patients that for some reason do not tolerate the cholinesterase inhibitors. The one area that is ripe now with a lot of media reports, a lot of studies, are these anti-amyloid beta monoclonal antibodies. The two that are on the market are lecanemab and donanemab. There were two very large studies, the Trailblazer studies, one of them, and they basically, there were large multi-center placebo-controlled double-blinded studies looking at patients with Alzheimer's disease. And what did they find? These were patients that were diagnosed with either mild cognitive impairment or early Alzheimer's disease. There's very strict criteria in most academic centers to see who can qualify, because there's a very long list of contraindications, and they have to show evidence of amyloid plaques, either on a PET scan or in the CSF. This is where it gets a little tricky. These medications were approved by the FDA back in 2022. They do show a statistical significant reduction in amyloid plaques on the brain imaging. So there were really significant, like, removal of the amyloid plaques, but it only translated into a little bit of slowing of progression by about 25 to 30%. And that meant it delayed progression by about 4 months. Again, it does not improve cognition or function. So there's like this mismatch between what you're seeing on the scans versus clinical change. So this was a big problem when the FDA approved this. There was a lot of backlash on this. What are some of the side effects? These are the big problems with these medications. The side effects, they're ARIA related, and they call them amyloid related imaging abnormalities. And the H is hemorrhaging and the E is edema. So the brain can bleed or you can get swelling, and they're usually related to the infusions. Some of them are asymptomatic. Sometimes people have headaches and other symptoms. That is why then you have to do serial brain MRIs. These are very standardized protocols that the patient and caregivers have to follow. The challenges are, it's just expensive. It's a big commitment. You have to get infusions everywhere from 2 to 4 weeks. It depends on the medication, and you need serial brain MRIs. Other treatments for dementia, which I just want to touch on, you got to treat the vascular risk factors, right? You have to treat the cholesterol. You have to manage their medications. Some patients benefit from an aspirin, but that's a very individualized discussion. Treat any underlying mood or anxiety problems. As again, Dr. Spano was mentioning with the SSRIs, very beneficial for these patients. Really emphasize good sleep hygiene, but avoid sleeping pills. All right, and there's a lot of data behind that. Okay, so these are our pets. And we're open to questions. I'll stop
Thank
sharing.
you guys so much.